All right. Thank you, everyone, for joining us for this media briefing about COVID-19 in Idaho today. My name is Nikki Forbingor, and I will be the moderator. Please note that everyone should be muted unless they are speaking. ASL interpretation is available today. If you search for the ASL interpreter and hover over the three little dots in the window, you can lock it in place on your screen. We are very pleased to have Governor Little start us off today with some opening remarks, and then he will leave the media briefing. Health and Welfare Director Dave Jeppesen will then provide some remarks along with Dr. Kathryn Turner and Dr. Christopher Ball, and then we'll open it up for media questions. With that, I will turn it over to Governor Little.
Thank you, Nikki, and thanks to all of you for joining us today. In just a few weeks, Idaho students will be returning to their classrooms for the new school year. And once again, it has become so important for us to protect their ability to learn safely in their classrooms with few interruptions. With more and more Idahoans getting vaccinated since the start of the year, we have seen a steady decline in cases throughout spring and summer. But now, COVID variants are spreading, and we're seeing more COVID cases and hospitalizations across the country and here in Idaho. Thankfully, more than 750,000 Idahoans have chosen to receive the vaccine. All along, our goal has been to protect lives and critical healthcare capacity. That is still our goal. And the vaccine has been hugely important to us. But with the new school year upon us, we should renew our commitment to our students. Simply put, we need more Idahoans to choose to receive the vaccine if our kids have a chance at a normal school year, one that is entirely in person without outbreaks and quarantines. The COVID vaccine is safe and effective. It's been tested, and yes, some see side effects, but they're generally very minimal. The vaccine almost guarantees that if you get COVID, you won't get as sick from the disease if you've been vaccinated. But don't take my word for it. If you're among the folks who are still waiting to see about the vaccine, please consider talking to a doctor about it. Not only for your sake, but to assure our kids are safe and back in school. I appreciate the members of the news media on the call today for your help in getting out good information about the vaccine to help combat a lot of bad misinformation out there about it. And as always, thank you to Dave and his crew at Health and Welfare for hosting these calls so we can continue to communicate with Idahoans about the vaccine. Thank you.
Thank you, Governor. Okay, with that, we will turn it over to DHW Director Dave Jeppesen.
Well, thank you, Nikki, and thanks to the governor who joined us today. Well, I have really two main points I want to make today. The first is that the Delta variant is here and the dominant version of the virus in Idaho. And that's really the underlying driver of why our coronavirus metrics have really gone the wrong way for the last several weeks. And in fact, the last time we've seen numbers like where we are right now was back in January to March earlier this year. We continue to see the number of cases rise. The statewide 7-day moving average of cases per 100,000 was down as low as 3.3 per 100,000 on July 5th. And as of yesterday was 18.4 per 100,000. For many weeks, we had almost all of our counties with less than 10 cases per 100,000. And as of now, we have over half of our counties above 10 cases per 100,000. COVID-19 testing positivity, which is a good indicator of virus activity, is increasing from a low of about 2.8% a few weeks ago up to 8.0% today, or as of this week. And we continue to see the number of cases at long-term care centers rise. We had seen that declining for many, many months. We're now seeing that start to rise. And then perhaps most concerningly, we see an increase in the number of COVID-19 patients in the hospital and in the ICU. In fact, we've seen those numbers more than double since July 1st. And as we look forward, we see the fall with the return of the flu season and people returning to more indoor activities, which leaves us concerned. So that was message one, is the Delta variant is here and it's moving our numbers the wrong way. Message number two for me today is that there is good news. We do have the vaccine widely available in the state, and we're starting to see the vaccination rates increase. Over the past 2 weeks in particular, we've seen the number of first doses start to rise. That's good news. And in fact, we just passed 50% of those 12 and older getting a first dose. For those of you that have chosen to get the vaccine, I say thank you. For those of you who have not been vaccinated, I urge you to consider getting the vaccine. It is the way that we will bring this pandemic to an end. As evidenced by the over 160 million Americans and over 750,000 Idahoans who have taken the vaccine in the past year, we know the vaccines are safe and very effective. And with that, I'm going to hand it over to Dr. Ball.
Thank you very much, Director. And I'm very pleased to be here today. And I'd really like to start off by thanking all of the clinical laboratories in Idaho that have taken an opportunity to send samples into the Idaho Bureau of Laboratories for sequencing. This has been incredibly valuable for us. Just in the month of July, we've received over 1,000 samples from 25 submitters around the state. And this is really helping us get a much better picture of the variants of SARS coronavirus 2 that are circulating in Idaho. And unfortunately, as the director alluded to, we've seen a very big switch in a very short period of time. To give you a little bit more information, if we look at sequencing that was performed on positive samples that were collected between the middle of May and the middle of June, the most abundant variant that we saw was the alpha variant at about 76%. If we just fast forward another 30 days and start looking at sequencing that was performed on samples that were collected from the middle of June to the middle of July, not only did we see an increase in the number of samples sequenced, but we saw 81.3% of those sequences being returned as the Delta variant. This rapid shift in variant composition is very consistent with what we've seen in other states. And we can certainly say that the Delta variant is widely circulating in Idaho right now. With a little bit more information about why this is happening and what it may mean for Idahoans, I'm going to turn it over to Dr. Turner so that she can provide a little bit of additional detail. Dr. Turner?
Thanks, Dr. Ball. And thank you for participating in the media briefing, and good afternoon. So as Dr. Ball just described, the Delta variant of the virus is here in Idaho, and the precipitous increase in our daily case counts that Director Jeppesen summarized is certainly additional evidence that the Delta variant is circulating in our communities. This variant is much more transmissible than previous variants of the virus, such as the Alpha variant that we detected circulating in Idaho earlier this year. And with previous virus lineages, what we observed is that a person who was infected with the virus went on to infect, on average, somewhere between 2 and 3 people. However, recent studies of outbreaks associated with people who have been infected with the Delta variant have indicated that when that person is infected, they will in turn infect somewhere between 5 and 9 people. One way to think of this is that the Delta variant is at least twice as contagious as the variants that have circulated recently in Idaho. So that's very concerning. The numbers can be somewhat abstract. There isn't a lot of difference between a person infecting 3 people versus 5 people, right? It's just the difference of 2 people. However, increased transmissibility poses an exponential threat. Even if the transmissibility went from, say, 3 people on average to just 4 people on average, over 10 generations of transmission, you would have 500,000 additional infections, which is 1/4 of Idaho's population. So even though that average number of people infected that difference is small, when you start multiplying that, it can have significant impacts. The other concerning aspect of the Delta variant is related to what we refer to as the viral load of people who are infected. And scientists have looked at how much virus people have in their nose and throat when they're infected. And it appears that those who are infected with the Delta variant tend to have more virus, and that it is detectable much earlier after exposure compared to infections with viral lineages that came before. It's possible that the incubation period, which is that time between when a virus enters your body, starts to replicate, and then you're able to spread it to others. It's possible this incubation period is shorter with the Delta variant. So there's a combination of factors: a shorter incubation period, a higher viral load, and then the biological aspects of the variant that help it invade human cells. All of these factors together explain why this variant is so concerning and why recommendations have changed recently as new science has emerged about this variant. This includes the recommendation to wear masks indoors if you're in an area with substantial or high transmission. However, as Director Jeppesen mentioned, there's good news, and that is that the currently authorized vaccines in the US do provide protection against this variant, and vaccination is one of the best ways to reduce the chance of additional viral mutations in the future. It's possible this variant may result in increased vaccine breakthrough infections, but recent investigations of outbreaks that do include vaccinated people tell us that those who are vaccinated are significantly less likely to have severe illness that requires hospitalization or leads to death. So I'm going to leave it there. I'm going to go ahead and turn it back over to Nikki Forbing-Orr to help facilitate the question and answer period.
All right, thank you, Dr. Turner. We will now take questions from our media participants. Please raise your hand in WebEx or type your question into the chat area. And when I say your name, please unmute yourself and announce your name and media outlet before asking your question. And then as a reminder, please remember to clear your hand when you're done. I see the first hand here from Audrey Dutton.
Good afternoon, Audrey Dutton from the Idaho Capital Sun. Can you talk about how the Delta variant seems to be affecting hospitalization and case rates among children? We've been hearing about more occurrences and more pediatric hospitalizations and more severe illness from around the country. Is that what we're seeing in Idaho as well? And this question could be for, I actually don't know who it's for.
Thanks, Audrey. Kathy Turner here. I'll go ahead and take that one and then see if my colleagues have anything to add to it. We in Idaho have not necessarily seen an increase in pediatric hospitalizations. As you know, our numbers are sort of small, so I think that we would detect a significant change fairly quickly. However, with regard to identified infections, we are seeing a difference. And just recently, as of last Saturday, the case rates among the littlest of the littles, so our 0 to 4-year-olds, babes to preschool age, their case counts are increasing have increased about 200% in the last 2 weeks. And we're also seeing the same thing with early childhood or early school age kids, 5 to 12. They're doubling. And then our teenagers, our 13 to 17-year-olds, we're not seeing quite as steep an increase in infections, but they have also increased substantially. So we've seen increases in all of the age groups, but we're certainly seeing a relatively larger increase in the younger population, and that could very well be due to the circulation of the Delta variant. And I don't know, Chris Ball, if you had anything to add, or Director Jeppesen, anything from your perspective?
Nothing for me, Dr. Turner. I think you answered that question great.
Yeah, Dr. Turner, I usually look to you for those answers, so I'm going to leave that with you. So.
One quick follow-up question. Given the increase in the 0 to 4 and the school age children, the unvaccinated population essentially, what should school leaders be thinking about right now? What should parents be thinking about? Director, do you have any thoughts?
Yes, thank you, Audrey. That's a great question. I think, as I mentioned in my opening comments, as we get to the fall and as school starts up, I think that's going to be an interesting time for us as a state. The CDC has recently issued guidance that for K through 12 education, that masks should be worn for both vaccinated and unvaccinated. particularly for this reason, which is we have an unvaccinated population of under 12 that are not eligible to receive the vaccine, at least not yet. And that's really meant for their protection. Obviously, it'll be up to the school boards and school districts to make their own determination. We actually have convened a back to school task force that will be issuing some recommendations here in the next couple of weeks to hopefully give some guidance to those school districts and school boards as they consider how they want to approach this fall. So yes, we are concerned about that, and mainly because that population is not vaccinated and can't be vaccinated. And as Dr. Turner illustrated, we are seeing an increase in infection case rate there.
Okay, we'll move on to our next question. This is going to come from Shira Matsuzawa.
Hi, thanks, Nikki. You know, previously there was talk about the state changing the way the Delta variant was tested for, and Dr. Ball talked about, you know, the sequencing changes and how that's given us a better picture of the Delta variant here in Idaho. Can Dr. Ball or Dr. Turner maybe talk a little more about those changes and just, I guess, a little more in detail for us?
Yeah, Dr. Ball, you want to take that?
Sure, Dr. Turner, I'll start. So the way that we've changed our testing request to clinical laboratories has changed in response to our ability to start sequencing greater volume of samples. So all through the spring, we at the Bureau of Laboratories and our affiliated partner sites have been building capacity to perform more sequencing. As we've developed more capacity to accept more samples, we've asked clinical laboratories to move from largely a variant detection type of a protocol where they would send us samples that they suspected may be variants of concern to really looking at proportional data. So really trying to accept all or most all positive samples from clinical laboratories. Because we have greater ability to sequence more samples, we can move into kind of getting a broader, more randomly selected sampling from around the state that will help us determine not only what variants are here, but in what proportions they're here. So we're finally starting to see the fruits of that hard effort coming to pass. And we're really seeing every week an increase in the number of samples that can be sequenced.
Thank you.
Okay. All right, we'll move on to Nicole Blanchard.
Thanks, Nikki. This is Nicole Blanchard with the Idaho Statesman, and my question is probably either to Director Jeppesen or Dr. Turner, really whoever is interested in taking it. I'd love to talk a little bit more about the increase in vaccine uptake. Could you maybe talk a little bit about where we are at right now, and what sort of increase we're seeing? And obviously, it seems like Delta is a contributing factor to that increase, but is there anything else that might be contributing to more people choosing to get vaccinated recently?
So Nicole, I think what I'm going to do is go ahead and turn that question over to our immunization program manager, Sarah Leeds, who's been able to join us. Sarah, do you want to take Nicole's question?
Sure. So I think that the Delta variant, it makes sense that that would certainly have an impact on people wanting to choose to initiate the vaccination process at this point. It's really hard to say with accuracy what exactly is pushing that, because we have a lot of communication efforts and education efforts going. Physicians are certainly reaching out to their patient population and providing education every time they can. We are trying to get the vaccine out in multiple ways at community events and concerts. And so we don't know exactly what's driving that, but my guess is that the Delta variant is one piece of it, and there are other factors as well.
Thanks, Sarah. Nicole, I'd just like to add that what we have seen an increase in vaccination among adolescents and teenagers, and that may be due to the fact that they're going in for their checkups before school starts, and they're getting their routine immunizations, and Idaho providers are recommending the COVID vaccine too. And so that may be part of why we're seeing an increase.
Okay, our next question is going to come from Vinny from Bloomberg. Vinny, I'm really sorry, I don't want to butcher your last name, so I'll let you say it and tell us how it's said.
Thank you. It's Vinny Del Giudice, and I'm a reporter with Bloomberg News in Denver. I cover the Rocky Mountain region. Dr. Turner, a follow-up on your pediatric data. How many little children 0 to 4 are infected at this time, if you have a tally? And how serious is this? Is this going to be a high-risk group as winter approaches? Is this something that worries you? Thank you very much.
Thanks, Benny. So yeah, I can give you absolute numbers, but I think what I'll do is I'll describe the increase. So the data that we have from, oh, I'm on the wrong slide. The data we have from 2 weeks ago indicate that about 16 per 100,000 0 to 4-year-olds were reported as being infected with the virus that causes COVID-19. As of last Saturday, that had jumped up to 53. So we went from 16 per 100,000 to 50 per 100,000 over the course of 2 weeks. So that's a significant jump. The numbers, I think, are a little less illustrative. But to your other point about what to look forward in the fall, I do think that our 0 to 11-year-olds are really the most vulnerable population we have right now. There is no vaccine that's authorized for these kiddos, and so it's really incumbent upon the adults in their lives and older teens to be vaccinated to sort of cocoon these kids away from, the risk of becoming infected. So does it worry me? It does. And as Director Jeppesen just mentioned, that is why some of the requirements or some of the recommendations have recently changed, and it is in response not only to the Delta variant, but how we're seeing the distribution of infections across our populations.
Thank you. Thank you very much from Denver.
Okay, our next question is going to come from Heather Ann Wagner.
Yes, Heather Ann Wagner from KPVI News. I wanted to ask about the transmission from vaccinated people. There's been a lot of mixed reports that I've read, so I wanted to know if there was an update on that, and also potential boosters, where we stand with that for already vaccinated people.
Okay, so I'll go ahead and take that, Nikki. I feel like I'm the only one talking, which is disconcerting, but so you're right. There are mixed messages about infections among vaccinated people, but I think what I'll do is I'll refer to a study that my colleagues at the Massachusetts Department of Public Health recently released. And you probably have all heard, it's been in the news recently because it was sort of the thing that sort of spurred CDC into changing their recommendations with regard to mask recommendations of vaccinated and unvaccinated people. And that is, there was an outbreak during, kind of the busy tourist season in Massachusetts, in Provincetown, Massachusetts, beautiful city, just sort of on the Cape. And this outbreak had about just under 500 associated cases with it. It is still ongoing. They're still in the middle of an investigation, but they have published some of the early results from that outbreak investigation. And you're right, they found that a large percentage of the people associated with that outbreak were indeed vaccinated. Massachusetts does have a very high vaccination rate. And so these would be considered breakthrough infections. And it's not unexpected to see vaccine breakthrough infections with any vaccine, but this was particularly striking because of the proportion. However, I think if I took anything away from that study, it is that even though there were those who had been vaccinated who were positive for the virus, they did not have severe illness. There were no deaths in these people, and there were just a couple of hospitalizations, and those people did have underlying conditions that would have put them at high risk, whether they were vaccinated or not. So I do think that the story here is that vaccination does protect you from severe illness, from hospitalization, and from death. And that's the message we've been sending all along. We totally expect to see a few vaccine breakthrough cases among any given population.
Thank you so much.
Okay, I just want to take a minute here. My webcam has frozen, but I want to make sure everyone can still hear me.
We can hear you, Nikki. We just can't see you.
Okay, good. Well, I'm not going to mess with it so I don't mess it up further. Our next question is going to come from Ian Stevenson.
Thanks, Nikki. This is Ian from the Idaho Statesman. I have sort of 3 quick follow-up questions about sequencing, so probably for Dr. Ball. So my first question was that my understanding is that in June, the state was able to sequence about 9% of PCR tests that it received. I wondered if there's a updated number on what percentage the state was able to sequence in July. And then you also mentioned that the state's been working on increasing capacity for sequencing. I wondered if there's a percentage goal that you're aiming for on that front in terms of being able to get a proportional amount of positive tests. And then lastly, I wondered how quickly after a test is actually taken from someone and marked as positive and then sent on to sequencing, how quickly is it become available to state officials who are able to, once it's determined what sort of variant it is?
Thanks, Ian. Those are 3 really good questions. So I'll try to take them in order. You are correct. We did some estimates earlier in response to, I believe, an inquiry from you about the percentage of cases, positive cases that are positive samples that are being sequenced. And we did estimate that was about 9% for June. We haven't estimated for July yet, but I can kind of give you a sense of where we're at in terms of just raw sequencing numbers. So earlier in the spring, we were averaging about 50 samples per week just kind of on a regular basis. As we started working with some additional partner laboratories and also increased capacity at the Idaho Bureau of Laboratories, we made a jump in June to about 200 to 300 samples per week. This last week in July, we sequenced almost 600 samples. So what we're seeing is just kind of incremental increases week to week. So there's a number of factors that can impact how many samples we sequence. One is just kind of the frequency with which they're delivered at the laboratory and the way that we can repackage those and send them out to our partner laboratories as well as testing them in-house. As to your question about whether or not we have a sort of numerical metric for gauging success of sequencing, at this point we don't. I think what we're really looking to find is that we get a good proportion of samples from every region of the state, so that the value that we're looking to gain from sequencing is not necessarily how many samples can we sequence in a given week, but what are the end results of that? Can it help us determine the proportion of variants that are moving and changing in the state so that we can best inform guidance moving forward? So I think we have a good example of that happening through June and July as we increase the volume of samples that we were sequencing, as well so the sort of depth of sampling. And with that increased depth of sampling, we're able to track this big sweep of the Delta virus into the state and virtually replacing all of the other variants that were in circulation. So in my mind, that's really the more valuable information to be taken away from the sequencing effort, is not necessarily what percentage of positives are we sequencing or how many raw sequences are we generating every week, but are we able to scale our sequencing to be able to effectively monitor changing variant dynamics in the state so that we can provide information to the public to better inform what mitigation efforts they may choose to take. So knowing that the Delta variant is widely circulating and the most abundant strain in the state, that's helpful for driving public health action, like saying this would be a really excellent time to get vaccinated if you haven't, or this is really an important consideration if you're considering increasing distancing or wearing masks when you're in indoor settings, regardless of whether or not you're vaccinated or not. So I think that's how we're choosing to evaluate the success of the sequencing program. based on the value of the data that we're generating, not necessarily the numbers, if that makes sense. And then I'm not sure what the last, if I addressed your last question or not.
Thank you. But the last question was just when someone takes a PCR test, how quickly is it able to be sequenced and then actually available for you all to look at?
So generally speaking, we're only able to receive samples that are a molecularly amplified test. So that's something that is done in a central laboratory. So there's some logistical pieces that can impact that. The first being, what's the amount of time between shipping between the sample collection site and the sample testing site? And oftentimes that's going to be less than about a day. And then typically the sample testing is also going to be another day or two before that sample is determined to be positive. At that point, most laboratories are trying to group together positive samples for submission to the Bureau of Laboratories. So you may have another day or so lag there, and then the shipping delays. So typically what we're seeing is we're receiving samples about a week or so after they've been identified as being positive. Sometimes it's a little shorter, sometimes it's a little longer, depending on what laboratory is submitting samples. So many of the local laboratories, for example, will get samples to us right away because they can courier them over on a daily basis. Once we receive the samples, we need to accession them into our laboratory information management system, repackage them, and many of them we send out to some of our sequencing partners, both in-state and out-of-state. So we've got some additional shipping there, or we'll test them ourselves. And so really, I think it's a long way to answer your question. It's typically about 2 weeks, 2 to 2.5 weeks before we get a sequence result back from the original sample collection time.
Thank you.
Okay, we have one final question from Audrey Dutton.
This question is regarding ER visits from COVID. So the dashboard, I compared one day's numbers with what my sources were seeing in the ERs, and the dashboard numbers are definitely a drastic undercount. And I think we've kind of suspected that for a while because it's kind of an automated process that service uses. What are you hearing from hospital leaders on their ER traffic from COVID? And is there a way to get more accurate numbers, especially as we're starting to see ERs get overwhelmed?
Thanks, Audrey. I think I'm going to see if Director Jeppesen would like to take that question first, and then maybe we can add to it.
Sure, happy to. Thank you. You know, we actually, early in the pandemic, the ER monitoring was a great tool that we used to see where virus activity was taking place. Since then, testing has ramped up, and that's actually become both positivity and cases identified our best tool to really identify what the virus activity looks like. We continually work with our hospital providers to make sure we're getting accurate data feeds on what's happening in their facilities. We publish that data on our website as well, and you can see that in our hospitalization, both the daily census for hospitals and ICUs. But I was not aware that there may be a disconnect between what our data is showing around COVID-19 ER visits and versus what hospitals are actually seeing. And so that's something Audrey will take a look at to see if there is a disconnect there. And we're always interested in improving our data so we can share that data back out with the public so they can see what's going on. So I appreciate you bringing that to our attention, and we'll dive into that and see if there's an issue there and what we can do about it.
Yeah, thank you, Director Jeppesen. And Audrey, I will tell you there is a little bit of a lag in our data, and so that may be part of what we're seeing, but we'll certainly follow up. I do want to own up and let everyone know that we had a really beautiful visual to show you regarding some of the data that Dr. Ball and I have presented to you today. And so I'm going to steal the screen right now and share that for you in case y'all want to maybe grab it. We'll also make it available after the, oh, that's not it. Are you guys, what are you guys seeing?
Right now we're there we go. We're seeing the visual there.
Okay. and I can't make it any bigger and still have it fit on the screen, but essentially what this is showing, as Dr. Ball mentioned in his opening comments, is, you know, sort of that progression of increase of the Delta variant among the specimens that have been tested by the Idaho Bureau of Laboratories, and that's here at the top. And then a really clear picture of what increased transmissibility means when we say that a person, you know, could infect 2.5 people versus a person infecting 5 to 9 people, and the number of cases that could lead to over time. And so wanted to make sure that you all had this visual. I think it illustrates sort of our main points that we made today pretty clearly. And Nikki, I'm going to turn it back over to you since we're past our 30 minutes.
Yes, thank you, Dr. Turner. When noting we are about 5 minutes past, we'll go ahead and wrap things up for today. We are planning another media briefing at 2:30 Mountain Time on Tuesday, August 17th. So we'll see most of you then, and thank you for joining us today.